Welcome to this case-based video on chronic obstructive pulmonary disease, or COPD. We will follow a patient from his initial presentation through his diagnosis and ongoing management, covering the pathophysiology and clinical care required at all training levels. Let us meet our patient, Mr. H, a 64-year-old man with a significant smoking history. He is presenting with a 3-day worsening of his baseline cough and dyspnea, accompanied by a change in sputum color. His exam shows tachycardia and hypoxemia, which will guide our assessment. In the first half of this video, we will define COPD and its two main components, emphysema and chronic bronchitis. We will explore the core pathophysiology, including inflammation and air trapping, and explain how these processes lead to clinical symptoms and pulmonary hypertension. In the second half, we will focus on the practical clinical approach. This includes interpreting spirometry, applying the GOLD assessment groups, and building a comprehensive treatment plan for both chronic maintenance and the management of acute exacerbations, while avoiding common clinical pitfalls. Reviewing Mr. H's history, we see a clear pattern: a chronic baseline cough now exacerbated by a recent viral trigger. This presentation of acute dyspnea and color-changing sputum is highly characteristic of an acute exacerbation of COPD. His history provides essential clues. With 40-pack years of smoking and a family history of emphysema, we need to consider both the environmental impact of tobacco and the potential for underlying genetic factors like alpha-1 antitrypsin deficiency, despite the lack of early liver symptoms. Physical examination confirms significant signs of obstruction. We observe pursed lip breathing, a barrel chest, and hyperresonance. These are indicators of hyperinflated lungs, where air trapping forces the diaphragm into a mechanically disadvantaged position, significantly increasing the work of breathing. To define COPD properly, it is a progressive, largely fixed airflow limitation. It encompasses two primary, often overlapping processes: emphysema, which destroys the parenchyma, and chronic bronchitis, which is a disease of the airways. Unlike asthma, this obstruction is not typically reversible. COPD is a massive global health burden and a leading cause of morbidity. While most cases are driven by cigarette smoke, smoking cessation remains the most effective intervention to slow disease progression. It is a largely preventable condition that demands early recognition. Emphysema and chronic bronchitis offer distinct clinical portraits. The emphysematous pink puffer suffers from dead space ventilation, while the bronchitic blue bloater experiences significant shunt. Recognizing where a patient falls on this spectrum helps guide our understanding of their physiology. Pathophysiologically, the journey begins with inhaled injury. Irritants trigger inflammation, recruiting cells that release proteases and oxidants. This leads to the destruction of alveolar walls and the remodeling of small airways, manifesting as the structural damage we see in COPD. The protease-antiprotease balance is central to this damage. Under normal conditions, alpha-1 antitrypsin protects the lung. However, smoke can inactivate this protection and increase protease activity. This imbalance leads to the digestion of the elastin scaffold in the lungs, causing emphysema. As airways narrow and lung recoil is lost, air becomes trapped, leading to dynamic hyperinflation. This increases residual volume and forces the chest into a permanent state of expansion. This mechanical disadvantage directly contributes to the severe dyspnea our patients experience. We must differentiate between dead space and shunt. Emphysema destroys capillaries, wasting ventilation. Chronic bronchitis plugs airways with mucus, wasting blood flow. Understanding these two V/Q patterns is crucial for interpreting blood gas results and clinical presentations. Finally, chronic hypoxemia can lead to cor pulmonale. Hypoxia causes pulmonary vasoconstriction, which eventually forces the right ventricle to fail due to increased afterload. Clinical signs like peripheral edema and a loud second heart sound should alert us to this serious complication. Let us map the risk factors onto our patient. The dominant cause is cigarette smoke, which drives central-lobular emphysema and affects 15 to 20% of smokers. Mr. H has a 40-pack year history. Recurrent infections also drive inflammation, and he has 2 prior episodes of bronchitis. Alpha-1 antitrypsin deficiency causes early-onset panasonar emphysema. Given the family history, we should keep it on our radar. Finally, a low lung function in early adulthood sets a lower lifelong trajectory for patients. Starting point matters. Alpha-1 antitrypsin deficiency is the classic can't-miss cause. Suspect it if the patient is under 45, has minimal smoking history, or has lower-lobe predominant disease. Look for extrathoracic clues like liver disease or family history, and confirm with a serum level. Keep in mind that alpha-1 antitrypsin is an acute phase reactant. A normal result during an acute illness can be falsely reassuring. The GOLD guidelines recommend screening once for this deficiency in all patients diagnosed with COPD. Moving to clinical presentation, the triad of chronic cough, sputum, and exertional dyspnea is classic. As disease advances, watch for frequent exacerbations, morning headache suggesting carbon dioxide retention, and weight loss. Mr. H exhibits all of these clinical signs. The physical exam findings flow from hyperinflation. You will find an increased AP diameter or barrel chest, hyperresonance to percussion, and decreased diaphragmatic excursion. Auscultation reveals diminished breath sounds with a prolonged expiratory phase, plus characteristic wheezes and rhonchi. A nuanced diagnosis is the asthma COPD overlap syndrome. Here, features of both exist in one patient. Reversibility of obstruction and presence of eosinophils in the blood can guide therapy, specifically when deciding on the use of inhaled steroids. Spirometry is essential to confirm the diagnosis. The hallmark is a post-bronchodilator FEV1/FVC ratio below 0.70. This demonstrates fixed obstruction, distinct from asthma. Only screen patients who have symptoms. Do not screen asymptomatic individuals. Supporting PFT findings include hyperinflation and reduced gas exchange capacity, measured by DLCO. A low DLCO points toward emphysema due to lost surface area, while a preserved DLCO more likely suggests pure bronchitis or asthma. Imaging like a chest X-ray can support your diagnosis. Look for hyperinflated lung fields, flattened diaphragms, and an increased retrosternal airspace. Because of the chest shape changes, the heart often appears small and vertical, sometimes called a teardrop heart. Regarding lab work, an arterial blood gas reveals hypoxemia. Hypercapnia, or elevated CO2, typically appears only once the FEV1 drops significantly. An acute rise in CO2 lowers the pH, resulting in respiratory acidosis, which informs your ventilation strategy. Classification of COPD is based on GOLD spirometric grades. We categorize by FEV1 as a percentage of predicted value, ranging from GOLD 1, mild, to GOLD 4, very severe. As these grades worsen, both mortality and clinical risk increase significantly. Risk stratification goes beyond the FEV1 number. We use symptom scores like the CAT or MMRC to assess burden. Crucially, a patient's exacerbation history is the single best predictor of future events. Imaging markers, like a wide pulmonary artery, can also flag risk. Treatment is grouped by GOLD category. Group A patients start with a single bronchodilator. Group B and E patients are started on dual bronchodilator therapy, while Group E patients may also require inhaled steroids based on blood eosinophil counts. No matter the group, smoking cessation and vaccinations remain non-negotiable foundations for all patients. Pulmonary rehabilitation is vital for those in Groups B and E, and oxygen therapy is reserved for specific hypoxemia thresholds, as it is the only therapy proven to reduce mortality. For advanced emphysema, procedural options exist, though they are reserved for carefully selected patients. Bronchoscopic lung volume reduction uses valves or coils to collapse the most diseased regions, improving function but carrying risks like pneumothorax. These are specialist referrals, not first-line treatments. We now return to Mr. H and his acute exacerbation. Everything we've covered so far relates to the chronic disease. Now we must address the acute event. We will learn to recognize it, treat it, and know exactly when to escalate ventilation. Clear thinking here saves lives. An exacerbation is a sustained worsening beyond normal variation. Infections are the most common trigger, involving bacteria like Strep pneumoniae or H. influenzae. Do not fixate solely on infection. Pulmonary embolism is a critical, can't-miss mimic. Look for increased dyspnea, cough, and sputum volume. Treatment pillars include inhaled bronchodilators and systemic steroids. Use ipratropium and albuterol every 1 to 2 hours to address reversible bronchoconstriction. For steroids, 40 milligrams of prednisone daily for 5 days is standard. They improve recovery but carry complications, so consider limiting them if eosinophils are low. Antibiotics help a subset of patients. Initiate them when you see increased sputum purulence combined with higher volume or dyspnea. Any standard respiratory antibiotic, like doxycycline or azithromycin, is acceptable. No single agent is superior, and a 5-day course is usually sufficient for mild to moderate disease. Oxygen management is a delicate balance. Target a saturation of 88 to 92%. While high-flow oxygen can worsen carbon dioxide retention through mechanisms like the Haldane effect and blunted respiratory drive, hypoxemia kills faster than hypercapnia. Maintain the target saturation, then monitor the CO2 level closely. Non-invasive ventilation is a high-value intervention. It significantly reduces intubation rates, hospital stays, and mortality. Start it for patients with moderate to severe dyspnea, falling pH with rising CO2, or a high respiratory rate. Always screen for contraindications like hemodynamic instability or inability to clear secretions. If non-invasive support fails, do not delay intubation. After the acute storm passes, prioritize long-term prevention. Arrange follow-up, enforce smoking cessation, update vaccinations, and consider a pulmonary rehab referral. These steps are what keep patients out of the hospital for the next exacerbation. Let's summarize common pitfalls. Avoid flooding patients with oxygen, and never forget that PE can mimic an exacerbation. Suspect alpha-1 deficiency in younger, non-smoking patients. Remember that bronchodilators precede inhaled steroids, skip mucolytics, and recognize that only oxygen and smoking cessation are proven to reduce mortality. Closing the loop on Mr. H, we have a clear diagnosis: an acute exacerbation of chronic COPD. Our plan: aggressive bronchodilators, short-course steroids, targeted antibiotics, controlled oxygen, and early consideration of NIV. Long-term, we must initiate maintenance therapy and comprehensive follow-up to optimize his future health. To wrap up, remember 5 key takeaways. COPD is a fixed airflow obstruction driven by inflammation and proteolysis. Stage patients by FEV1 and clinical groups. Treat in steps, prioritizing bronchodilators. Finally, master the acute exacerbation with a disciplined, evidence-based approach to ventilation, oxygenation, and medical therapy. The teaching in this video aligns with current evidence, including the GOLD 2024 report and major clinical trials. Please verify all clinical images and specific trial data before use in your practice. Generically citing your local guidelines is the best practice for clinical accuracy. Thank you for watching. This topic connects to another video in our series. You will find a link on your screen now or in the description below. Click through to continue learning, and I will see you in the next lesson.